is institutional and political and policy related, is where the patients find themselves with very specific problems that relate to their own health, their own treatment options and so on. So that's why I'm particularly glad that Ananda Plate is here. She's from, technically speaking, the myeloma treatment group, the Myeloma Patients Europe, but Ananda knows the subject very well, and I'd be very grateful if you'd give us your view of needs from the patient perspective, maybe taking account of what Federico has already said on that broad perspective, but what is it that patients, cancer patients, want in Europe, Ananda? So, do you want to do it from here? With the greatest of pleasure, if you like. Yeah, sure. Where's our expert with the slides? Thank you very much.
It's that one, the PowerPoint. So, I'm not sure whether you know Myeloma Patients Europe, MPE. We're an umbrella organization of myeloma groups across Europe. And basically our main aim, we don't have individual patients as members, we have patient groups as members. So I'm going to focus a bit on the needs of our patient groups that directly relate to the patient needs at a local level. We have 36 members, just for you to get a feeling. And sorry, I have a bit of a cold, so if I start coughing, apologies. With regards to our strategic objectives, I'd like to highlight two of them, which have to do with the project I'm going to talk about today, which are the capacity building of our member groups and really the limitations of access. Thank you so much, Peter. Which Federico also highlighted in terms of equity. Access is one of the main issues we have. So what I really want to get over here is the fact that, in myeloma specifically, over the last decade, we've had huge advances in research. It's been really great, wonderful. However, we see that there's still issues in access, and this is not something that concerns some countries. It's really something that happens across Europe. So we, as a patient organization, at a European level, what we thought was needed is to really find out what the reasons behind that was. Advocacy hasn't been successful over the last decade. That's something we have to really acknowledge and see, and find out why that is. So our hypothesis was that, of course, we have challenges. We really know that the outcomes aren't optimal. We know that many patients aren't getting access to the treatment they need, and really finding out what is happening at an advocacy level. So me as Ananda, when I'm in Brussels and I get emails from our patient organizations telling me, look, Ananda, I have this patient who had to travel to Turkey to get a drug because it wasn't available in X country in the European Union, or just because we weren't getting reimbursement, so the cost was too high to pay out of pocket, we went to some other country. All of that anecdotal reporting is given to me to advocate, and go and lobby Federico, for instance. And I can't do that because it's not hard evidence. I can't go to the European Parliament or to the European Commission and tell them, look, here's, an article in the Daily Mail telling that patient X doesn't have access. So we really felt the need of focusing on evidence. Patient advocacy needs to move from anecdotal reporting, which is very good to, raise attention in media, to evidence-based advocacy. Really know exactly what is happening in the country. So we developed this approach, this Atlas approach, which basically what it does, it creates a platform of evidence for our member groups to use. So what we do is to really find out what the clinical evidence is, identify the barriers of access in each of the countries. Then we develop a strategy for each of the member groups in each of the countries to really identify what the priorities are in that specific country or for that specific group. And then we provide them with a set of skills to really carry out that strategy at a local level. So just shortly to tell you how this tool is, what the methodology is behind this tool. We have a desk research, so we analyze the clinical guidelines in myeloma, the main ones, to really have a clinical base on what a minimum, I'm not going to say standard, I think some people in the room are allergic against the term standard, but the minimum treatment that any patient should expect to get no matter where they live. And then we also had a broad compilation of information on health systems to really identify what the underpinning issues are with regards to access, the barriers to access. And that was, complemented with a very comprehensive survey. We included 40 myeloma clinical experts, I think 35 member groups across 34 countries, to see what the perceived barriers in access were for these people, for these two, I'm not going to say stakeholder groups, but for these two groups that are crucial in this system. And so what the output, it should actually say output and instead of outcome, is a report which will have, the perceived barriers, then the picture of how the health system looks, so you can identify what the reasons might be behind those barriers, an interactive map to really make it attractive and sell it out there. But then we have an implementation phase, which is like really finding out the strategy you want to use in each of the countries and providing the skills to our members. The timeline is not important for you, although it is important to know that the project will be launched at the end of the year and will implement probably the pilot next year. And we found out a great interest of other groups in other disease areas who really also felt the need to have that evidence base to advocate at a local level. So we think that this is adaptable. It's not only myeloma focused, it can be adapted to anything. And I mean, since we're talking here about the specificities of, Central and Eastern Europe, this might be, interesting for you to see one of the results of the survey, which shows you the upper countries are the Western countries, and the ones on the bottom show you the perceived barriers to access in Eastern European countries. And you can see there's pretty much red down there, obviously, and at the far right you have a bit of the socioeconomic data as well to really make sure that you're not comparing, Germany with Romania, for instance, which you would never want to do. Just as an example. But it is interesting for patient groups then to see, why within all those green areas is there a red spot in, access to innovative treatment in Switzerland, for instance. So what is behind that? Let's go and look at, the points of the health system to see what can be behind that. So this is just an illustration of what patient advocacy can do, to maybe contribute to this not only debate, but in really trying to work together for a solution. Obviously, to get the data, we need collaboration, we need experts, we need the regulator on board, and we can't do it alone. But we, have the motivation, which is the patients who are dying at the moment. So that's me.
Very good. Thank you very much for that, Ananda. One thing that comes out very obviously from there, I see I've got a very wide chair. Is this some sort of suggestion? For my maps. I'll ignore it. Just sit on it. One of the things that comes out very obviously from what you say there, in fact it was almost your opening remark, that advocacy hadn't got as far as you'd hoped or wanted. And you said partly it was because it was at the moment based on anecdotal evidence. How far is it something that really should depend on patients advocating to get the level of care and treatment that they, I think one can more or less say they deserve, or certainly they believe they deserve? And how far is it something that should be happening anyway because of the overall system? I'm not trying to lay the blame on Federico, but as he says, there are certain commitments that the EU has in this area. The Commission, among other institutions, backs it. So does it strike you at all as odd even that you're in a position where you have to be advocating to get what one might say was considered yours by right?
So absolutely. I mean, we're doing it anyway. If it doesn't happen, we'll have to do something about it. But you're right, from the regulator side, there needs to be a commitment. But this doesn't only come from the European Union. I think within the competencies that the European Union has, and I'm not putting my European Union hat on, but it is not the only thing we need. We need political will and really commitment from the member states to do something about it. And imposing it from above, for me, has limited benefit. You can have some guidelines and you can, incentivize member states to really collaborate, but it's really so specific. Health systems, unless we really have some commitment in situ, I think, and since that's not happening, so we need to do something about it.
Okay, does that sort of thought, well, does any of what Ananda said spark any particular response from you guys in terms of questions or comments? One of the things I'd also like to know is, and you said a little bit at the end, obviously you're doing this for myeloma, and I'd be interested, even though you're still only at the stage of putting together the outline for it, so you're only still working on anecdotal evidence, but I'd still like to hear what anecdotal evidence you might offer about the differences that are observable, even on a slender base like that, between different parts of Europe. But also the extent you said it's something that could be transferable, or the methodology that could apply in other areas. How far is myeloma representative of the general cancer challenges across Europe? How far are you aware of other areas of cancer where there are evident deficiencies that are analogous to the deficiencies that you remark in treatment of myeloma?
So I believe that the most active, or like the best example of patient advocacy happening isn't in cancer particularly. I think that the HIV community has done a brilliant job in really professionalizing and getting that evidence together and really being that example to follow. I'm not aware of anything happening in cancer at the moment which is similar to the Atlas. That's why we did it. Otherwise, it would be duplicating what has already been done. And I do believe that it's absolutely necessary. I think I mean, breast cancer has a lot of attention, so they do a lot of very effective and efficient advocacy. But besides that, I'm not aware of, those cancers that aren't particularly popular at the moment, doing anything like that. And that partly has to do also with the fact that groups are very heterogeneous. So across Europe we have very developed and professionalized communities like Myeloma UK, for instance, and we have others which, I'm not going to give examples, but which are based maybe on one volunteer running the whole organization. So you really have some limitations there as well.